Okay, so I'm going to make a start, everybody. First of all, welcome to this session, which I think is a very, very important session. Obviously, for those of you who are not going to be able to join us today, we will be sharing this session with you. But as a first thing, just some ground rules. So at the moment, what we're doing is we're going to have 30 minutes of peer review till 7:30. And then after that, Abhijit will be talking to us with a little bit of revision of ultrasound physics. And I think the reason I wanted him to do that is because it is a very important, very crucial aspect of what we learn. But subsequent to that, what he will be doing is actually covering a lot of what we see as abnormal lung. In particular, some of the pathologies, some of the signs that we see. Uh, so by the end of this session, we would have done 15 days now, or 2 weeks of training, where if I summarize what we have covered is the physics of lung ultrasound, artifact, uh, the normal lung and its appearance, but in particular what the abnormal lung looks like today. And from here onwards, what I would like to emphasize is that we're really starting the business end of your learning, because what we would expect now is that if you are able to and can share your screens and presentations with videos, you can use them and we can critique them and we can do peer review, which then kind of means that you'll be able to share your knowledge with us, and obviously from our perspective we'll learn from you. So I think I can't emphasize enough how important the coming sessions are. The session that I'm going to take on Tuesday in particular will summarize what I call is standardizing nomenclature. So what it aims to do is to put together the last two talks and summarizing exactly what standard terminology we will be using as a group when we're trying to describe our scans. So without further, without taking up more time, I'm going to hand over to Kirti. I'm going to mute myself, and Abhijit, you can unmute yourself.
Yeah.
Okay, so this was a late preterm baby with tachypnea and grunting. I did this scan at about 10 hours of life. There were no risk factors for sepsis, and this baby was only on a high flow of 4 liters for a few hours.
Mm-hmm.
This was the chest x-ray that we had. These were some of the images that I had taken. So because I have a linear probe, I couldn't really divide the chest into upper anterior and lower anterior. It covered more or less the entire length of it altogether. So the first one is left anterior. I think that's the lung sliding, which I have marked. On the left lateral, it's the ribs, the pleural line, and the skin and soft tissue. I have placed left posterior here just to make it uniform, but I think my depth could have been more because there's just more of superficial part which is visible on this one. Then in the right anterior, I suppose those are the A lines. That's the bat wing sign that I've tried to show in the right lateral and the right posterior. I think that next to the B lines, those small ones are the comet tails, which I might be wrong, but I thought the tinier ones, which are not going all the way deeper down.
Right.
Then I tried to take the seashore sign. Is that clear, or it didn't seem like a real seashore that you see in the textbooks?
Yeah, I mean, lovely images, Katie, but there is not much of an information to say, how much the depth was at that point on your scans. So can't really comment on, I mean, ideally it should be around 3 to 4 centimeters, your depth, and it would have been easier to comment on the scans when you have those depths and your focus, marked on the screen. So you keep your focus at the pleural line. About the seashore sign, yes, it looks like a seashore sign, but yes, it could, I would say it could have been a bit better, but yeah, it's a lovely one. And another comment on the scans, we try to keep, you've depicted your bat sign and A lines and B lines, all are coming up lovely. But we try to keep our probes as perpendicular as possible, rather than getting a slanting image or slanting ribs or the pleural lines. We try to keep it as perpendicular as possible because the lung ultrasound is the whole, it's a game of artifacts. So we try to get it as perpendicular as possible to get the best of the artifacts view.
Is there a way to know in the image whether the probe I'm holding is perpendicular, or have I slanted it a bit? Does anything come out more prominently when you hold it perpendicular?
Yes. So the reason we are trying to put it as perpendicular as possible because that is the point where you're gonna hit the pleural line at 90-degree angles, and that's where your the A lines are generated the best, or your B lines are seen the best. Is there a way to know how we're gonna put it as perpendicular as possible? It's just by looking at the image. If your A line is coming straight up, or the pleural line is coming straight up, then it's a perpendicular. You're being perpendicular to the pleural line. If you see it's sort of a slanting image, then you're not being perpendicular. And try to keep your probe, when you're talking about being perpendicular, try to keep it as perpendicular as possible to the ribs. It might not look like in a real baby, but we try to keep it as perpendicular to the ribs as possible.
Okay.
And about your comment on the lung rockets and the B lines. So the best way to differentiate between the two is, yes, you're right, B lines reaches all the way to the bottom of the screen, and whereas the lung rockets or the comet tail artifacts doesn't. Number one. Number two, your comet tail artifacts should not be erasing the A lines. Now on this image, they are erasing the A lines. I couldn't see the A lines, so my best bet would be it would be a B lines. As we can see, there is some loss of gain in the image on the lower portion, so we might have lost the acquisition there. But my bet would be it is still a B line because it's erasing the A lines.
Okay, thank you.
Mm-hmm.
And this, I think, was the liver image. And then next to this, I tried to do transdiaphragmatic.
Mm-hmm.
I didn't do the scoring because I wasn't sure how to score R1, R2 because I don't have anterior upper, anterior lower. So I left it. Okay, that's all. Thank you.
Yeah.
So just
Dr. Alok?
Yeah, Dr. Phanipriya, I can hear you. Yeah.
Sorry. So I'm sorry to interrupt.
That's all right.
I thought
That's okay.
the case. I just want to make sure whether I'm audible.
You're audible. That's correct.
Yeah, I'll try to share my screen also.
Sure, sure. Just while Dr. Phanipriya is sharing her screen, I think I agree completely with Abhijit's comments. One of the things that can sometimes help, Kirti, in particular, to make sure that your probe is 90 degrees, is you should be able to, when you're using your linear probe, see multiple ribs in parallel with the pleural margin parallel to your probe. Now, the challenge becomes when you go into the upper axilla on the right and left sides, because getting a linear probe into the axilla is a real challenge. So what happens is you get foreshortening of your image in the superior axilla. So classically, I would say R1, R2, not too difficult. But as soon as you hit R3 and L3, you're really looking at the upper axilla. And my advice would be in those situations, get a nurse to basically abduct the arm so that you can actually get your probe completely into the axilla and completely perpendicular so that it's not slanting, it's not angulated. Similarly, I would say that just occasionally when you're on the back, there's the scapula. The back is quite challenging. The posterior regions can be quite challenging to get really good images at 90 degrees. And one thing that I sometimes do is to get the back straight, I'll put a small shoulder roll under the baby, in particular under the shoulder, to kind of get the shoulder straight. I'll also try to image quite lateral to the spine. So, the back is quite big. And as you slant, sometimes you're more lateral at the back. So try to keep yourself as close or just lateral to the spine and image those areas. And it might mean you have to move the image laterally to try and get your best image in that situation. So you might actually end up getting, quite a few images for R5, R6, just to try and make sure that you've got your image acquisition really nice. Other thing, again, just to mention, as Abhijit mentioned, is that you're losing your image acquisition at the bottom. So, I suspect that's probably depth. So I think your depth is okay, but just be careful of not interpreting that loss of image acquisition as consolidation. So you did have a nice consolidation there in one of the images, but I tell you what, Kirti, can you share those images again next time?
Yeah.
Okay. So Dr. Phanipriya, go ahead, please. Have you shared your screen?
Yeah, look, I have started sharing my screen. It is visible, right?
Yeah, it is visible.
Thank you. Basically, hello, good evening, everyone. So I'm Dr. Phanipriya from PGI Chandigarh, India. I want to discuss today the basic settings which I was using in the machine, because I'm not very accustomed to lung ultrasound and also ultrasound machine in particular. So I wanted to show what all settings I've done. So the machine used was Philips Epic 7C, and I have these knobs there, where on the left side I could change the time gain compensation, and on the right side I have only three knobs to adjust. One is for zoom, other is for depth, and third one is for focus. The three knobs which are on the right, these are the three things. These are only the things which I could adjust. And then I've used the probe, linear probe L123, and it is a kind of adult size. So I've selected that probe, and then I could see only carotid artery, carotid general, vascular carotid, vascular venous axis which are there. So I didn't know which one to use. So I've used the vascular venous module I have selected. So these are the settings which I have done. These were all settings which were set prior to this module. Uh, so I've tried to see what are all the settings, how to see the plural line, to see for lung sliding, and to see for A and B line pattern. So this is baby K, 34 weeks baby, 2 kg, currently 15-day-old. Was a preterm, had HMD, was a post-surfactant. Currently 15-day-old, but...
Sorry, Dr. Phanipriya,
yeah,
you might just want to go into slideshow.
Yeah.
Thank you.
Sorry, I'm sorry.
That's all right.
Yeah. So this baby was a case of hyaline membrane disease, required surfactant, and then had persistent tachypnea. Currently is on HFNC 2 liters per minute, but there is no oxygen requirement. So only issue is baby is having persistent tachypnea. Echo was done, which was normal. There is no evidence of PPHN or any other structural heart disease. And the settings which I've used, I've already told, and depth I have set at 5 centimeters. So this is the first image I tried in the L1 region. So here, I can see pleural sliding, and also on M mode, I'm able to see the seashore sign, and there are no A lines visible. I could see batwing sign and multiple B lines.
Yep.
Yeah. Yeah. And
Right.
then this is the image which I've taken from in the left uh, L3 area. So
Mm-hmm.
this is also showing uh, there is a good pleural sliding. Pleura is well visible, but I could not make out any A lines. It is predominantly densely packed B lines, which I could appreciate. And then this is on the back. As you have explained, I had a lot of difficulty in doing the ultrasound on the back. I could not get clear picture, and this is the picture which I could get.
Sure. Right. Okay. Fanipriya, if you can go to your first, image, the slide, the
Yeah,
first.
sure.
Yeah. Um, yep. Yeah, as you rightly said, there's a pleural sliding, pleural line, there's a bat wing sign appearance. I can't appreciate any A lines in this particular image. And you have beautifully demonstrated the M mode, getting the sandy beach or a seashore sign. Just to critique this particular frame here, what I would have done is your focus is way down. I would have loved to keep that at the pleural line. I don't know if you can see my pointer,
Yeah,
but
yeah. I could get. I understood.
yeah, so your focus should be at the pleural line, because that's where your the whole game is. So I would like to keep the focus at the pleural line. Then it will give you more crisper image. That's number
Right.
one. 5 centimeter of depth is fine, but for babies, 3 to 4 centimeter also does the thing, and you don't have a blackout areas on the screen if you keep it at 3 to 4 centimeter. Here we don't see any blackouts or any fallouts
Yeah.
of the image, but sometimes you do get in a situation like that. That's one thing. And I think the second thing I would have done in this particular image is about the gain. Now I really can't say how much it should have gone up or down, but first thing is the focus, and once we keep the focus, it auto adjusts most of the time, and if it doesn't, then you have to sort of tailor it to get the best of the image there. So yeah, otherwise lovely image. Yeah.
Is there a
Thank you.
way
Thank
to
you. Yeah.
So just one comment, just to add a fantastic kind of image, but just for those of you, if you see on the right side of the screen, there's an X3. That X3 is actually the focus, and that is what you have to really get to the pleural line. So you want to get that at the margin of the pleura. Now, the reason why this is so important is because the pleura here looks quite, I'd say, irregular, and it's blurred, and really the problem could be that your focus is below, so that's why you're interpreting the pleural line like that. So hence Abhijit's absolutely right. What you really want to do is get your level at the level of the pleura, because you might find that you actually interpret the pleura in a different way in its appearance.
Right. Look.
Yeah, and the only other thing is these are lovely compact lines. They're beautiful. Yeah. So well done. Thank you. Carry on.
Thank you. Thank you.
Yeah.
Thank you.
One more thing I would like to add for all the participants. When we are presenting it, if we can keep the video on the loop, it becomes easier to interpret, because it runs for half a second or so. So it really becomes difficult. So if you keep it on a loop, in a slideshow, it becomes easier to interpret the images.
Okay, Dr. Abhijit. I have few queries regarding the settings. As you have told, we should change the gain in this particular machine, because in other eco machines there is an option for changing gain, but in this machine I could not. There is no option to change the gain. Only TGC is there. So how could I have done it? Only thing which I could I could changes the all the things which are shown on the left, like there is a RS which is written, and then C might be contrast, and P low, I think, is penetrance low and resolution low.
I'm not well versed with the scanner you're using, but sometimes what happens is if you change your, like you have used the vascular mode, so I'm sure there will be something as musculoskeletal mode as well, or superficial mode, and the machine gives you an free hand to change your gains. Some of the scanners also comes with the eye scan button, which does the
this
job for
comes
you.
with eye scan.
Yeah, so if you hit the eye scan, it automatically adjusts. But mind you, first we need to get the focus right before we hit that eye scan, because it's gonna focus on that particular area where you are keeping your the focus at. So try changing the mode and see if you go to superficial and the machine allows you to change your gain settings.
Okay, thank you.
Right?
Yeah, thank you. I have only a single case for today.
Okay. And we'll talk about all these A lines, B lines, and artifacts today in our session today. So I haven't dwelled too much on the images, but guys, I've got a beautiful images. We're going to talk about all these artifacts and its generation and everything in the session, and how to optimize your scan. Yeah.
So Anna, would you like to share your screen? Are you presenting today?
Yes, I can present.
That's beautiful. We'd be very grateful. Thank you so much.
I can see the to share the screen button.
Yep.
Can I ask something?
Yep.
So if there's loss of A lines or artifacts in the deeper part of the screen, is there a way that we can fix it? Can I do something to make it better?
Loss of, you're asking particularly about loss of A lines in the deeper part of the screen?
I mean, loss of any lines from the, because some of my images, we could see the superficial part, but deeper down there was loss of. So what do you think happened there?
Again, it has to do with the depth, focus, and the your gain settings. So we're going to talk about how to optimize those things, and not to have a fallout of images in the session today. We'll talk about it on the session.
Okay, thank you.
Yeah.
I can see the invitation to share. I can see it. Can you invite me again, Alok? I can see to share the screen. I have not that invitation. Are you listening to me?
So I can hear you, Anna. Yeah.
I can't see the. Oh, now it's here.
Yeah.
Okay. Can you see my slides?
Yes.
Okay. So can I start?
Go ahead, Anna.
Okay.
Yep.
So we have a male late preterm boy with a birth weight of 1,620. He completed the prenatal corticosteroid maturation. It was a C-section because of the mother with preeclampsia and fetal growth restriction. He born well. He was connected to CPAP with a low FiO2 needing, and the blood gas were okay, and he was okay during the first day. in the day after, I could do a ultrasound. I don't know how I can take this out. And these are R1, and we can see sliding well, and the A lines, they are predominant. And in R2, we can see I think we can see a double lung point here. Because here more B lines and at top more A lines. And these are free. We can see when the baby is in expiration, the pattern is worse with more collapse and then more aerated when he is in inspiration. I think it's very well seen here.
Yeah.
And this is the left side. A bit worse with more B lines than the right one. And L2 and L3. And I think you can see the double lung point again here. So I guess for the clinical and the ultrasound, it was a transient tachypnea of the newborn. But the day after this, at 6 a.m., the baby gets worse with polypnea, respiratory distress, no saturating well. And I was on duty and did ultrasounds. And here I was a little in doubt if there was a lung point here, because this was not sliding so well. I did M mode, but I was a bit confused because I don't know if this was a barcode sign or not. I was starting ultrasound, I was not so confident. So I did in another mode. I tried again, and I think this is more clear that we have the lung point. This is sliding, and here not sliding so well. And the M mode, I think here is more clear barcode sign.
Absolutely.
So this was the X-ray. I think I have to. Okay. And we confirmed that there is a pneumothorax in the right side of the chest. And just to say that some days later, I repeated the scan and it was great. Lung sliding, no lung point, and the baby was fine. And here, the seashore sign. Well, in between, it was taped with a needle and drained the hair. He didn't need to be with a drainage, only the needle to take the hair off. So I think is this. I don't have more slides, I guess. These are my settings of my lung settings in my ultrasound machine.
Right. Yeah. This is a GE machine, isn't it?
Yes. Yes.
Yeah. Oh, yeah, I can see that. Yeah. Yeah.
The focus.
Yep. Excellent images, Anna, and very nicely depicted lung point and seashore and the sand. What do you call stratosphere sign or barcode sign? Yeah, lovely images.
Thank you.
think what I'd highlight with this case is the fact that, you're going to be able to make this diagnosis very quickly with lung ultrasound, as opposed to having to wait for the chest X-ray, expose the baby to radiation. I think there is, however, a learning curve where while you're learning, doing the chest X-ray, helps to back up your diagnosis. And this is what I would say to all the participants at this particular point, is that while you're actually learning lung ultrasound, don't hesitate to use the chest X-ray as your gold standard. To start off with, a lot of us, when I started learning lung ultrasound, I would actually look at the pathology on the chest X-ray and kind of think about what I would see on lung ultrasound. And then in the course of my learning, I've gone back to doing lung ultrasound first, thinking of my diagnosis, and then doing a chest X-ray to kind of validate what I think after clinical correlation. And now I think I've reached a level where I feel that actually I don't need a chest X-ray. So what you'll find is all of you will go through this gradually, and using the chest X-ray to interpret your findings would be fantastic. Abhijit, you've got some questions in the chat. So what I was going to say is that, Rana, we're going to let Abhijit tell us that when he takes us through the talk. Is that okay? So one of Rana's questions is, can we quantify the size of the pneumothorax? So I'll let Abhijit cover that when he gives his talk. I had Zahreddin also raise his hand. Zahreddin, did you have a question?
A quick one, look, thank you so much. What is the medical legal stand on chest X-ray versus ultrasound to prove a pneumothorax?
So actually what I'd say to you is that the sensitivity and the specificity of the combination of a lack of pleural sliding, an A profile with a barcode sign is much higher than a chest X-ray. I'd also say to you that there are pneumothoraces, very small ones that a chest X-ray might not pick up, that can be picked up by lung ultrasound. In particular, I would say smaller air collections, which might be a very small amount of air. And there is absolutely no doubt. I mean, from a diagnosis perspective, lung ultrasound is much more sensitive and specific. I think a chest X-ray, is obviously something that we've learned. I would say that what is very important is how you clinically correlate. Like we're used to doing a chest X-ray, waiting, seeing if the baby's stable. Most of us in this particular situation where the baby doesn't have a tension pneumothorax would probably get the chest X-ray to try and quantify how severe the pneumothorax is. A lung ultrasound can do that very, very effectively. I mean, in terms of medico-legal kind of grounds, I think if you clinically correlate, demonstrate on a lung ultrasound that you've got a pneumothorax clinically, you have time to wait. I would still do a chest X-ray. The reason for that is, I think it's helping my diagnosis. It's helping aid my diagnosis. Clinically, I think if I've got a tension pneumothorax, I'd probably be making that diagnosis clinically, and lung ultrasound would be supportive. But I'd probably be needing that on clinical grounds. Transillumination in extremely preterm babies, and I'll just give you an example, can actually be positive even without having a pneumothorax. And I've recently been in a situation where I've had a baby who's 24 weeks who had very severe PIE. Now, the question from my perspective is, he suddenly deteriorates and starts desaturating 2 hours later, and I have to wait for a chest X-ray to happen. The question from my perspective is, if I transilluminate him, I might, and I did get actually positive transillumination. The question is that PIE or a pneumothorax? And I mean, the lung ultrasound was confirmatory. So I think rather than thinking about the medico-legal approach, I would say that, and this is what I will talk about on Tuesday, what is very important from our perspective is developing a guideline, which basically says, well, this is how we're going to diagnose pneumothorax, and then agreeing that, well, if the baby's stable, I might agree that I want a chest X-ray. I can tell you for a fact that in Paris, where Nadia practices, they don't do chest X-rays at all. And they treat pneumothoraces and they put chest drains in with lung ultrasound. And they use lung ultrasound to define the lung point, to actually define where the drain has to go in. That is also very important. So you can see how it really depends on the confidence that you have as a person performing the lung ultrasound, as to you make the diagnosis and you opt to treat. And I think that learning curve, that takes time. Does that help your question? I think if you had a guideline which said, and you were able to diagnose a pneumothorax, transilluminate, clinically correlate, and then drained it, I don't think anything would be a problem medico-legally.
Yes, thanks a lot, Alok. Thank you.
I'm going to let Abhijit share his screen because we're 7:30 exactly. Abhijit, go for it.
Yeah. Right, everyone can see my slide?
Yes.
Yes.
Lovely. Okay, so right, good morning, afternoon, evening to everybody from around the globe. So yeah, I've been tasked with the having these sessions on the abnormal lung. But before we get to the abnormal lung, we'll be going through the little bit of physics and then how this A lines, B lines, and all the signs and artifacts we talk about are generated, so that we have a grasp of a normal looking lung. And so we can make a judgment call that this is a normal lung. Anything deviates from this will be an abnormal lung. So in abnormal lung also, I'm just going to cover the kind of collapse consolidations and pneumothorax today. Yeah, so let's begin then. Right, so the objectives today, we're going to talk a little bit about the physics. I'm not going to dwell too much on it because Alok has at length spoken about the physics and of the ultrasound. So just a bit of physics, followed by a recap on the profiles so far we have gone through. We'll talk about pattern recognition, and then we're going to talk about the pneumothorax and collapse and consolidations at the end. So physics. We all know about the piezoelectric effect. Again, we'll just quickly run through these slides about piezoelectric effect, frequency and wavelength, acoustic impedance, what all this leads to in terms of the image generation, and what kind of a lung pathology changes in terms of getting this image with all these concepts in hand. So piezoelectric effect is very straightforward. It's about the crystal where you apply some electricity and it gives out ultrasound waves. And as the name suggests, it's the ultrasonic waves are beyond the range of 20,000 hertz, which is beyond our hearing range, and hence they are called ultrasonic. So, and piezoelectric crystals also have the property when it receives sounds, it generates electricity, which is decoded by the scanner and gives us an image. So that's piezoelectric effect. I'm not going to talk too much about it. So this is how the piezoelectric crystals are placed in the transducer, and so from here your sounds waves are generated. It go and hit the organ of intent and reflected back, or refracted, which is again decoded by the scanner and gives us a image or the video. Right, frequency and wavelength. Very crucial to understand here the concept of the frequency and the wavelength. Because when we know this, then we choose the right probe, not only for the ultrasound, lung ultrasound, for any point of care ultrasound, be it brain, abdomen, echoes, scans for the lines and stuff like that. So how you're going to choose your probe depends on this concept of frequency and wavelength of the ultrasound wave. So in terms of frequency, I would like to understand, I mean, this is how I think about the frequencies. It is a number of ultrasound waves generated every minute. Hertz is the unit of frequency. So if you have a higher frequency, that means you are generating more number of ultrasonic waves. The distance between, or the time between the two of, or the consecutive waves will be much less compared to the frequency which is low. That is, low number of waves are generated. So the time gap between the two waves will be higher. So this is what it is depicted here. So how it impacts us in a clinical scenario. So if you have a high frequency waves, then you get a very crisp image. You get a ultra high definition sort of image, but at the loss of the penetration. So you can use a high frequency probe to visualize any organ or structure which is very superficial, because it will give you a very crisp image, but it can only visualize the superficial organs. If you have to look deeper into the body, then you have to go for a low frequency, higher wavelength probe. So as to say, you want to look at the abdominal organs, then you would like to have a low frequency, higher wavelength probe. If you want to look at anything as lung, which is pleural line, very superficial. We always talk about the depth of 3 to 4 centimeters. So you can imagine it's a very superficial structure. Or, for the vascular ultrasounds, again, very superficial structure. There you need a higher frequency probe, which will give you a very crisp image of the superficial structures. So this is a relationship between the low frequency, the frequency and the resolution. So on your x-axis, you have your resolution, and on your y-axis, you've got your frequency of the probes. And you can see the phased arrays, the one which we use for the different thing from echoes, sometimes for the head scans and the deeper vascular structures in the abdomen. So you can see it's a very low frequency. So you can imagine it can go to very deeper organs. So you can see if you have a low frequencies, your penetration depicted by this purple line is quite high. So you can see very deeper structures with this, but at the cost of your resolution. You can see it has got, you can see anywhere, but you don't see a very crisp or high definition image of that. As your frequency increases, the curvilinear and the linear probes, as you all are using linear at the moment, so 5 to 15 megahertz, you get a very, you get a high resolution picture, but at the cost of the penetration. So you cannot see deeper structures, but whatever you see, the superficial structure, it gives you a very crisp image. Right, acoustic impedance. Acoustic impedance is nothing but it's a resistance to the sound waves. So you can imagine if you have a higher resistance, anything which has got a very high resistance, the kind of image generated from that structure will be bright white. And anything that has got a low resistance, say for example fluid, where it doesn't gives you much of a resistance to ultrasonic waves, so it appears darker or black in color in the scanner. So higher the resistance, higher the reflection. Higher the reflection, you get a very bright image. And lower the impedance, lower the resistance, you get low reflections, so you get darker images. So low reflection and low refraction as well. So this is what I said exactly. Reflection occurs when there's a large difference in impedance between the two tissues, and you get a bright white image. And refraction occurs when the impedance or the resistance is low, so that some of the waves can pass through that particular structure. Then you get refracted waves rather than reflected. This image will, the schematic will explain it better. So when you ultrasound waves are hitting a particular structure, for our sake, let's say this is a pleural line, it's gonna hit and then reflect. So this is your reflected waves, which will be interpreted by the scanner as it has a very high impedance, say 90% of your waves are reflected back. So it's going to give you a bright image. As you can see, the pleural lines are very bright and discrete. Say it passes through, liver or something, which is again, it's a low impedance structure or the organ. So you will have, say 100 ultrasonic waves are coming out, 50% got reflected and 50% get refracted. Refracted as in it can pass through the structure. And of course, there will be some reflection from there as well. And hence you will get more of a darker image. And this concept is important because from here we talk about the echogenicity, anechoic, isoechoic, hyperechoic sort of a structure. So we'll come to that again. And then there's attenuation and absorption, again, which depends on your acoustic impedance. If you have a very high impedance or high resistance, you're gonna reflect most of the waves. So you will not get much of an attenuation at that point. And there will not be much of an absorption. If it passes through some of the structure which allows the ultrasound waves to pass through, then you will get attenuation and absorption of the waves. And we will see how it impacts the image or the artifacts generated in the upcoming slides. So this particular phenomenon of attenuation and absorption gives us a shadowing artifacts, which is also called as a bat wing sign, as some of the participants has already demonstrated in the scan today. So attenuation gives us this shadowing artifact because when you hit something and is reflected back, anything beyond that structure has a fallout in the image because scanner doesn't perceive anything beyond that. So it will give you a blackout area and gives a particularly bat wing sign. So we'll demonstrate that as well. And then we have echogenicity. So anechoic, just to go through the terminology, anechoic is black. So fluid is black in ultrasound. Anything that is fluid will appear black in the scanner. As is depicted here, this is a bladder and is filled with fluid, urine. So it's anechoic and it's black in color. Then hyperechoic, bright white. So anything that reflects most of the ultrasound waves, that will give you a bright white color. Bone is the brightest, as you can imagine, and so is the pleural line. So so that's your pleural line, and it appears hyperechoic compared to your soft tissues in the vicinity because it allows the sound waves to pass on, and then it hits the pleural line and is reflected. So it gives you the bright image. Hypoechoic. Hypoechoic is nothing, but it's a it's a play between the anechoic and hyperechoic. So when we talk about hypoechoic, we are talking in terms of relative. So liver appears darker than the kidney. So liver is hypoechoic compared to the kidney. So or for that matter, bladder will appear hypoechoic to the kidney. So isoechoic is again in terms of relativity, it's similar in echogenicity. So your spleen and liver, or spleen and kidney, kidney cortex to be precise, are isoechoic to each other. So so it's just the play between the black and the bright white gives you hypoechoic and the isoechoic images. Right. So I think we all know why we do ultrasound scans, and I'm talking about point of care ultrasound. So which encompasses the lung ultrasound as well. So it's very limited. It is very focused, and it is always done by the bedside. So you don't have to move your babies or patients anywhere, and it's always done by the clinicians. So we are trying to find an answer to a very specific question when we are doing a point of care ultrasound, and so is the lung ultrasound as well. So it is always done in a clinical context, and I cannot emphasize it more. I think Alok has spoken many times about it. So it's all about the clinical context, the clinical background, because lung ultrasound, you don't see lung, you only see the artifacts. And those artifacts can be generated in wide variety of pathologies, in the wide variety of the clinical conditions. So to correctly interpret those things in terms of the clinical scenario, you need to have a background of the patient or of the baby. So it's very important it is done in a clinical context. A random scan without any background or the clinical background will not be able to interpret much. We can say these signs are there or these artifacts are there, but it won't be answering you in terms of pathology, what kind of pathology we are dealing with. And the POCUS always guide care. So you can tailor your care depending on your scan result. Okay, so we know when to do it. Now the question is, how do we do it? Right. So lung is a very simple organ, unlike heart, which is always moving in different chambers and, the flows and stuff like that, or the abdomen, which contains almost 21 organs. So lung is nothing like it. It's a very simple sac of, air. So it's a very simple organ. And mind you, in terms of, the point of care ultrasound where your heart, abdomen and other structures are involved, lung ultrasound is the most gross, because again, as I'm telling you, it's all about the artifacts. You don't look at the lung, you don't see lung, you only see the artifacts. So it's very gross. And all the science arises from the pleural line. Whatever it is we're going to talk about, or whatever science we're going to talk about, is all arises from the pleural line. Again, beyond the pleural line, there is air, which ultrasound waves hits it and it generates artifacts. So whatever you're going to see in the lung ultrasound is arising from the pleural line. Lung signs are mainly based on the analysis of the artifacts, as I've already said that. And lung is a dynamic organ, and so are the signs. So we always say that we don't take a snapshot of a lung ultrasound. Unlike the head scanner and thing where we take just a snapshot. You don't do that because the lung is dynamic, the pleura is moving, and we need all those movements to correctly interpret the artifact or to answer the specific question about the pathology. So dynamic scan. What kind of probes we used? We have already spoken, and Alok has already spent quite a bit of a time on the probe selection and all. Just to run past, phase arrays are mostly used. As you can see, it's quite low on the frequency. So it is mostly used for your deeper structures. It has a very small footprint as well. So it's mostly used for the echoes and all. Linear probe is the one which we'd like to use for the lung ultrasound because it has got the maximum frequency. So it gives you a very superficial and crisp image. Hockey stick is just the extension of the linear probe. It has got a smaller footprint, unlike the conventional linear one, but again, very high frequency and mostly used for the vascular structures or the lung ultrasound. Curvilinear is my favorite one. It's the most versatile one. You can look at anything or everything in the body, including the lung. We just have to be mindful of the limitation of it. But it's a great probe to have. If you don't have anything else, curvilinear will do the job. So phase array probes has a great penetration, but okay resolution because it goes deeper into the structure and it has a small footprint. Curvilinear, good penetration, good resolution, good probe, and it's the most versatile probe. So if you don't have anything, your curvilinear will get you through. Linear probe, or by extension hockey stick, has got a very poor penetration, but very excellent resolution. And this is, if you have it, nothing like it, you can use this for the lung ultrasound. Again, not going to go through this, but just to emphasize that why we are selecting and what you are selecting in terms of doing the scans. Right, artifacts. So there are a lot of artifacts we're going to talk about and how these artifacts are generated and what you interpret from those artifacts and how the lung pathologies give different kind of an artifacts. So reverberation artifact, we're going to talk about that. We're going to talk about acoustic shadowing, comet tail artifacts, and mirror image artifact. trust me, there are a lot more, but just to not to sort of, drown you guys with a lot of artifacts, I'm just limiting myself to this 4, and there will be a couple of more as we go up in the slides. Reverberation artifact, it gives us A and B lines. And just for understanding, A lines are generated when there is a horizontal reverberation. So reverberation is back and forth movement of the ultrasonic waves. So if your waves are doing this, then it generates A line. And we will see in the slides what I mean by this. And when we talk about the B lines, it is a vertical reverberation. So it is doing like this, back and forth, it will give you a vertical reverberation. So let's talk about the A lines, how it is generated. So you can see there's a soft tissue there, and that's a pleural line. The bright white line is a pleural line, and you can see those are the A waves. And A waves always come equidistant from each other. So up there is where you're going to put your probe, and white line is a pleural line, and down below the pleural line is all air. So when the ultrasonic waves hits the pleural line, it's go back and hits the probe because it's all reflected. So say suppose this is the transducer and it takes T time or T seconds to reach the pleural line, and it hit back and it generates the image of pleural line. But this sound wave is going to come back again because it's going to do back and forth because it is being reflected so much that it comes back again to the pleural line and goes back up. Now it is taken twice the time of the first wave. So it's going to generate one more line. That's your A line. By A, it means air. So air line. Again, third wave, the same wave, it's going to do back and forth and reach the probe again. So it has taken 3 times the times compared to the first wave. So it generates the third one here. So you can see the distance between your probe and the pleural line will be equidistant for all the A lines. This distance will always be the same, and hence the A lines are generated. A lines are generated when there is air. So A for air. You can see that's your probe. You're going to apply it on the chest. We are trying to keep everything as perpendicular as possible. There you can see your rib, and that's your bright line is your pleural line. So your ultrasonic waves are coming and hitting the pleural line, and it's doing back and forth because it's been pleura is being highly reflective, and none of the wave can pass beyond the pleura because there is air. So your A lines are generated equidistant from the pleural line. So this distance, sorry about that. So your distance from the probe to the pleural line will always be equal in terms of generation of the A line. Moving on. Again, depicting the same thing. I'd also like to talk about the pleural sliding at the same point of time. So nice and beautiful A lines here, pleural line, and then the A lines. You can see your pleura is sliding. So your parietal and the visceral pleura, the parietal pleura is static, but your visceral pleura slides along the parietal pleura. And it gives you an impression of an ant crawling effect. If you see, like the marching of the ants. So it looks more like an ant crawling effect. So if you see what I mean. So that's pleural sliding. And it's a very important sign. We always look at the pleural line first. The pleural line is present, and then we talk about the pleural sliding, and then we go to A lines and B lines and comet tail artifacts and whatnot. But always, is there a pleural line? Number one, and then is there a pleural sliding? The second question is always pleural sliding. And again, we like to give names, by the all stretch of imagination. So this looks more like a bamboo spine. If you see what I mean, it looks like the bamboo trees, Again, it's nothing but the A lines all the way to the bottom of the screen. Now, if I have to critique this image, everything else is fine over here except for your what do you call this, focus. And you can see if you keeping your focus here, which is not the right thing to do, it should be supposedly here at the level of the pleural line. You will see a lot of blackouts. So this focus into 3 should always be at the level of the pleural line, and we'll come to that again later. So that was horizontal reverberation, and now giving us A lines. Now let's talk about the vertical reverberation. Now vertical reverberation is this movement, and that's a pleural line. And then this bright white hyperechoic lines reaching all the way to the bottom of the skin like a laser is the B line. So this is how it is generated. So that's your fluid field alveolus. So these are different alveolus, and there's a septus in between, and there is your fluid. So whenever you do a scan and your ultrasonic sounds comes through it, as I said, it loves the fluid, so it has no problem coming all the way in. But then these alveoli are filled with air, so it reflects back and forth. So when it is reflecting back and forth, that's how your B lines are generated. So consider B lines as a curly B lines on the chest X-ray. It is same thing as curly B lines. So it is so you get B lines when anything that should be filled with air is getting filled with fluid. Now that could be, fluid, blood, or whatever, but it has to be some sort of a fluid, and then that gives you a B lines. Right. So here is the depiction of the B lines. So again, if you see this particular area over here, you can see these lines are reaching all the way to the bottom of the screen. Excuse me. Again, first thing first, is there a pleural line? Yes, there is a pleural line. There is a pleural sliding? Yes, you can see the B lines are moving all with your respiration. So yes, there is a pleural sliding. Can we see the A lines? Yes, we do see the A lines. These are the A lines. Can we see B lines? Yes, it comes up. And as I said before, if it is a B line, it's always going to erase the A lines. So you can see whenever the B lines are coming in the view, your A lines disappears. Yeah. So that's a B line. Let's talk about the acoustic shadowing artifact. So this gives us the bat wing appearance. It's a stretch of imagination again. Why bat? Don't ask me. I'll try to show you as much of a bat as possible on this lung scan, but acoustic shadowing gives you the bat sign. So again, this is the ribs, soft tissue. You apply your probe here, and then this is a kind of image that is generated. Bone being highly reflective, it reflects 100% of the waves back to the probe. So you see bone as very bright line, bright image, but anything beyond bone will be lost. So that's a shadowing because your sound waves are not penetrating through the bone. So it's 100% reflected back. So there's nothing to show beyond the bone. So that's a rib shadow. And then here will be your pleura, and through the pleura, because there is air here, your ultrasonic waves will always reverberate horizontally and gives you the A lines. So, and the father of the ultrasound, I think, Daniel Lichtenstein, has imagined this as a bat sign. So let's see if it looks like a bat. So there you go. That's a pleural line. And that's your bat. So bone will be the, you can see here will be your bone, and then there is your rib shadow, and that's your body of the bat. So this is the most I can make of a bat on a lung ultrasound, but you got the idea. So that's a bat wing appearance. So wing, shadow, body, bat sign. Comet tail artifacts, they are also known as the lung rockets. Again, you can imagine all sort of things. So this is what I'm talking about. So any line, just consider comet tail or the lung rockets as a precursor of the B line. So there is some fluid, maybe some drops of fluid. So it's not enough to generate that kind of a reverberation so that it reaches all the way to the bottom of the screen. But it is very short, and it terminates midway, and it doesn't erases the A line. So you can see there are some B lines there, which is reaching all the way to the bottom of the screen. But these are small rockets, which just ends up, it terminates midway. So that's where the are the comet tail or the lung rockets. Again, whenever we see the image, we always ask the same question again and again. Is there a pleural line? Yes. Sharp and discrete, smooth pleural line. Is there a sliding? Yes, of course, it is sliding. You can see lung rockets. If you see lung rockets or you see B lines, lung is sliding. And then you can see your A lines and B lines and lung rockets. Same thing over here. So these are small lung rockets. We are just terminating midway. Mirror image artifact. So mirror images are also a creation by the reverberation artifacts. So you see the mirror image of whatever you are scanning, basically. So when we're talking about the lung scan, so this is your soft tissue, your bones, and then you see a very sharp pleural line followed by the A lines. Where is the mirror image? You can see whatever, above the pleural line, you can see the same thing below the pleural line as well. So these are the mirror image artifacts. What it tells you? Well, it tells you for the reverberation, you need air to reverberate, basically. So what it tells you is there is air, and which is not letting the ultrasound wave to pass through. So it is bouncing back and forth, and it is giving you a mirror image. Whatever is on the other side of the pleura, it's showing the same thing beyond the pleural line as well. So that's what the mirror image is. And you can see mirror images in all the scans of the body. So to show you another example, so this is the curvilinear probe again, and you can see this is liver. That's your diaphragm coming here, and you can see the liver on both the side. Now you can see the vessels coming here, the same vessels coming here. What it basically tells you, if you can see a mirror image, the other side also is having some bit of air. So you can safely assume that, okay, ideally it should be looking like this. So you see your liver, and beyond the liver, you can see the vessels, you can see the vertebrae, but you don't see the mirror image of the air, because here there is no air. The ultrasound waves can pass through the organs. Here, on the other hand, because of the air, it cannot pass through, and it does back and forth, and it gives you a mirror image. So basically, it's a sign when there is a pneumothorax. Right. Now coming on to lung presets. So what kind of a preset? I mean, the new fancier machines have started coming with the lung preset now, but the old machines are also good. They are better, actually, without the harmonics, which sort of clear all your artifacts. So we're going to discuss what kind of a setting we can do to, make use of any ultrasound scanner to do lung scan. So the mode, we always use superficial or a muscular mode, because we're going to use a high frequency probe, and we are trying to look at a very superficial structure with a very good clarity. So we always use a superficial or a muscular mode or a vascular mode. All these are superficial structures. Then we try to focus our things. So whenever you put a probe, you have selected the probe, the linear probe or a hockey stick probe, and you are putting it on the chest of the baby. it immediately gives you some image, and there you first thing you focus is at the pleural line. As I always said, first question is pleural line. Is the pleural line visible? Yes. Is there a pleural sliding present? Yes or no, whatever. So we talk about the pleural line. So whenever you see the pleural line, get your focus on the pleural line. So once you've done that, you adjust your depth. Ideally 3 to 4 centimeter. You don't have to go beyond 4 centimeter, because you can imagine, the baby's chest and the pleural line will be just at 3 or 4 centimeter at max from your probe. So that's the ideal depth you'd like to get, so that you don't have the fallout of images. Width. So how much width you're gonna get? So ideally 2 intercostal spaces with the 3 ribs. Reason for why 2 intercostal space? Because then you're going to see the bat wing sign. Otherwise, there will be a bat with just 1 wing. And it becomes easier for you to interpret different artifacts when you have 2 intercostal spaces visible. So that 3 ribs is your ideal width. Gain. So how to adjust the gain? So if you are lucky enough to have an eye scan button on your scanner, just hit the eye scan. It just does the job for you. Otherwise, I'll not go to the nitty-gritty of how the gain, is gain settings are done. But just to understand, it is to make the image uniformly bright. That's the whole idea. So you can use your gain setting, the gain knob on your scanner, to uniformly brighten up the image. That's the whole idea. The most important thing with the new scanners, always switch off the harmonics. We don't need the harmonics, because harmonics, it kills the artifacts. That's the whole point of harmonics. So whenever you're doing your other scans like echoes and all, you don't want to see all the lines and artifacts, because you're looking at the organ. In the lung scan, we are looking at the artifacts. So we don't want to clear the artifacts. So switch off the harmonics. And some tips to get the good images. Position, very, very important, both of the babies and the operator, whosoever is doing the scan. So you have to be very comfortable, so that you don't have a catch or something. The babies has to be very comfortable, because if it's a fighting baby or resisting baby, feisty baby, you're not going to get a good image. You won't be able to focus on the particular section or the pleural line. So position is very, very important. Then ultrasound gel, pre-warmed, of course, for the holistic scan of the babies. We don't want to make them cool. So pre-warmed gel. And very important thing is, again, ultrasound waves hates air. So you want to take that air pocket between your scanner and the baby. So we have to use the ultrasound gel. Second most important thing with this gel application is, you don't put a lot of pressure on your probe, because if you put a lot of pressure, you can imagine it's going to squeeze out your gel. So if you're squeezing out your gel, it's no good. You're going to have some pockets of air again. So keep a very light hand while doing a lung scan, and believe me, it will give you brilliant images if you keep a light hand. And then, of course, always ask for help, be it your colleagues or nurses, to position the baby. As again, Alok has mentioned multiple times, it's very, very important to keep the baby contained, so that the baby is not fighting with you or the scanner, so that you get a good images. And ambient lighting of the room. This is again one thing I have noticed while we are doing scans, or we are having these sessions with our trainees here in UK. The well-lit rooms, window shades open or bright lights on, it's going to affect your scan. How? Because you're not going to have a proper gain function, because to you, the images will not appear as bright if you have a too bright of a surrounding, and you will sort of try to overcompensate that with the lot of gain, and it will make your images very fuzzy. So have a very ambient lighting in the room when you're doing the scan, just shutting the window blinds or dimming the lights while you're doing the scan. it gives you beautiful images. You'll try to, you will get the best of the adjustment on the gain and focuses. Right, moving on to the lung profiles. So A profile, air profile, A prime profile. There are a lot of what do you call this, protocols around the globe, and this is from the Blue protocol. They like to call it as A prime, but it's just an extension of the A profile. A for air. Then you have B profile, anything that fills up the pockets of air with fluid, blood, whatever, anything that is liquid will give you B profile. And combination of A and B, if you can see both, it's AB profile. And then there is a C profile. We'll talk about the C profile when we come to the images, but this is consolidation. So if you have a consolidation, C profile, very straightforward. A, B, and C profile. So A lines. For the A profile, of course. So A lines, they represent air, as we have discussed already. They are horizontal always. They are very sharp and they are discrete. They are repetitive and equidistant. We have gone through that, and it's a reverberation artifact, and it originates from the pleural line. And you can see A lines both in the normal lung, of course. Lungs are supposed to be filled with air, or you can see that in the pneumothorax as well. Pneumothorax, air again. So you see A lines in a normal lung and the pneumothorax. When do we lose A lines? When air is replaced by fluids. What kind of a pathology? Well, all sort of pathology. RDS, alveolar edema, transient tachypnea of newborn. You can see what do you call this? Bronchopulmonary dysplasias. So anything that replaces air will give you B lines. So that's when you lose A lines. Air is replaced by the blood and exudates in diseases like infection, pneumonia, hemorrhage. Again, you lose your A lines. You have a collapse of the segmental collapse, or small pockets of collapse in the lung, or you have a consolidations. Again, you lose your A lines. You get C lines or shred sign. We're going to talk about those things when we get to those slides. But this is what you see in pneumonia and atelectasis. So you can see there's a wide variety of pathology where you lose A lines. Again, artifact. So air, A lines, lose air, lose A lines. B lines. Right, nothing to do with the B. It's a curly B. It's been named B lines because it's a same thing as a curly B lines on the chest X-ray, and it depicts the same thing. In the chest X-ray, curly B lines, there is a fluid in the fissure. B lines on the ultrasound, there is a fluid in the alveoli or interstitial space. So they are well defined. They are hypoechoic. They are vertical lines arising again from the pleural line. Anything you see on lung ultrasound, all arises from the pleural line. Sideways and vertical reverberation artifacts. It erases the A lines, of course, because if there's fluid, there won't be air, and it moves with respiration, unlike the comet tail artifacts. It extends all the way to the bottom of the screen. That's the way you differentiate it from the comet tail artifacts. And because comet tail artifacts, they terminates midway, so it doesn't reach the end of the screen. But consider comet tail artifacts as the precursor of the B lines. If baby is getting worsening, you will start seeing comet tails, which will progress to B lines. And if the baby is improving, you will see, there were a lot of B lines or Qualis B lines, and starters getting better. Now we are seeing more of a comet tails, and then it disappears. So curly B lines of the ultrasound. Is it normal to have B lines then? Yes, if it is less than 3 B lines in one segment, and by one segment, I mean bat wing sign. So if you see 2 ribs, intercostal space, and in that particular intercostal space or a segment, if you see less than 3 B lines, that's acceptable, that's normal. It is abnormal if you have more than 3 to 5 is a gray area. More than 5 B lines is definitely abnormal, and beyond a point, it qualies and it gives us compact B lines. We're going to talk about that. And compact B lines or Qualis B lines, consider it as a whiteout lung in chest X-ray. When you see a whiteout lung in chest X-ray, something is fluid with air, or there's an inflammation, again exudates and loss of air, you see B line, you see whiteout chest X-ray. And exactly the same thing, you see compact B lines on the lung ultrasound. Here I have listed out the difference between the cometal and the B lines. I'm not going to read that out. We have already discussed this, but this is the difference between the lung rockets and the B lines. Moving on to the M mode. So we have done the scan in the 2D, and we have seen the artifacts. And now we want to interrogate the particular area of interest in the lung with the M mode. Why do we do M mode? Just to make sure that we are dealing with the right pleural sliding, positive pleural sliding, or are we dealing with the pneumothorax? And there are other pathologies as well. So M mode is a motion mode. So it's sort of a one-dimensional ultrasound view of the lung. Well, not the lung, of the pleura. So if you have an air, the lung filled up with air, and the well, no lung, I mean pneumothorax, all filled with air, you're going to get a barcode or a stratosphere sign. And if you have an air and fluid interface, which is normal in the lung, or in a pathologies like RDS and TTNB, you will see seashore or a sandy beach sign. It could be in the normal lung or in the pathologies where the lung is filled with the fluid, or in the interstitial areas. And if you see only fluid interface, I can imagine conditions like empyema, pleural effusions. In those kind of scenarios, you're going to see something called a sinusoidal sign. So basically, these are the three signs which we are trying to look at when we are interrogating with the M mode. So example, I'm sure it's clear to everybody. So this is the seashore or a sandy beach sign. You can see there's an air and fluid interface. How? It's all B lines, so definitely there is fluid. I cannot make it out here, but there has to be some air as well. And the pleural line. So we'll decipher this one in the upcoming slide about the barcode sign. So again, step-by-step approach of the lung ultrasound. I'm repeating myself a couple of times now. Is there a pleural line? Is there a pleural sliding, which is end crawling effect? And do we see A lines? Do we see B lines? Is there cometal artifacts? So these are the questions you answer, and then you, knowing combined with the clinical background, you come to a conclusion. I'll just run through this one because I've repeated myself a couple of times now, and I can see Alok has already shared the reading material from where it has been picked up. So I'll not go through this. But this is just an approach to, this is just an approach to come to a conclusion about pneumothorax. Right. We have seen pleural line, now pleural sliding. So end crawling effect, you can see 3 ribs, 2 intercostal spaces, nice and discrete, very crisp B line. You can see your focus right. You can see A lines coming up, and then there is some cometal artifacts. So if you see cometal artifacts or the B lines, you know for sure there is a pleural sliding. Even if you don't see it, you can appreciate very well that there is a pleural sliding ongoing there. If you see what I mean, that's the end crawling effect. It feels like the ends are crawling there. Same thing here. So there's definitely a pleural sliding and some cometal artifacts. When do we lose pleural sliding? Well, number of conditions. It could be pneumothorax, pleural effusion, collapse or consolidations, and chest tubes. So these are the conditions, to name a few, where you can lose your pleural sliding. Let's talk about pneumothorax now. Of course, there will be an absence of pleural sliding. You will see A profile, or as the Blue protocol likes to say it, as A prime profile. So it's all A lines because it's all air. There is no fluid. That's what pneumothorax is. So you're not going to see any B lines or cometal artifacts. So absence of B lines and cometal artifacts is A profile. When you interrogate that area with the M mode, you will see barcode or stratosphere sign, and it is a pathognomic sign for the pneumothorax. And you will see a lung point, which is again a pathognomic sign. It's basically a transitional zone between the normal aerated lung and the area of the pneumothorax. You might not see lung point if it is a quite a sizable one or a complete collapse of one side of the lung. Then you might not see the lung point. But if you see, it means there is a transition between the normal lung and the pneumothorax area. So this is an example of absent pleural sliding. So you don't see any B lines or cometal artifacts. Then what are we seeing here? Of course, that's a respiration movement and but transmitted to this particular segment of the lung, but you cannot see the pleural sliding. You cannot see any B lines. You cannot see any cometal artifacts. So this is a transitional area where you can see some B lines are coming up. Sorry about that. Oh. Right. Sorry about that. So that's a lung point now. You can see this is an area devoid of pleural sliding. You cannot see any B lines or cometal artifacts. Whereas this is the area where you can see nice pleural sliding. You can see your B lines moving with the pleura. There's a B line coming up here as well. So this is a normal aerated lung, and this is the area where there is a pneumothorax. So normal lung, and this is the area with the air leak, and that's your lung point, the transition between the normal lung and the air leak. And we interrogate with the M mode. So this is first the normal lung, seashore or a sandy beach sign. Again, it's a stretch of imagination, as I think in radiology, you'd all love to do that. So that's your sky. That's your sea. And this is your sandy beach. And this is what it looks like. So if you can imagine, so that's the sandy beach sign. Whereas barcode, it's straightforward. You interrogate the area with the pneumothorax, you see a barcode sign. If you see what it looks like, I'll show you the comparison as well to be very clear. So that's your barcode sign. And so this is side-by-side view. So this is a normal sandy beach appearance, and this is a barcode appearance. You can see this grainy area, which is not present here. The sandy beach is not present here. You do not see sky and sea over here. It's all lines. It's all stratosphere or the barcode like lines. And this was the same image, the video which I showed you just a while ago. So lung point, where you see a normal aerated lung and the pneumothorax. So when you interrogate these areas, in quick succession, this is a kind of image you generate. So when I was interrogating this area, I got the image of a sandy beach. As soon as I moved my cursor over here on the pneumothorax area, you can see the generation of this stratosphere sign. So this is how it looks like. Sandy beach, stratosphere sign. Collapse consolidation and atelectasis. So any loss of aeration, loss of A lines, alveolar or interstitial edema, it will give you emergence or abundance of B lines, which all will be true in the collapse or consolidation. You have a collapse, loss of aeration. You have consolidation, some degree of loss of aeration, and there will be, if it is a pneumonic consolidation, it will be filled up with fluids. If it is an atelectasis, loss of aeration. So, and you will get air fluid bronchograms, which will be static and dynamic. And I'll show you what I mean by that. There will be disrupted or irregular pleural line. This is not exactly the shred sign, but we'll come to it when we see the images. And there will be a loss of pleural sliding. So if you have collapse or consolidation or atelectasis, you will have all these features there. Depending on if it is a pneumonic or infective process, you will see kind of air bronchograms or fluid bronchograms, depending on the pathology. But there will be presence of all of this. And there is something called as lung pulse. It is not pleural sliding. It is just a transmitted cardiac pulse. And the good way to differentiate this from the pleural sliding is it will always be equal to the heart rate of the baby. So you can see the lung pulse, and I can see the heart rate on the monitor, and you can come to a conclusion that, you know, this is this transmitted pulsation is from the heart of the baby. Bronchograms and shred sign. So you see dynamic air bronchograms in consolidation. It is nothing but small pockets of air trapped inside the consolidated area. So whenever the baby is trying to breathe in and out, there is some degree of movement in that consolidated area, and that gives you the dynamic air bronchogram. Static bronchogram is, you know, when you have a collapse or atelectatic area, which is not taking part in the respiration at all. So whatever air has been trapped inside that atelectatic or the collapsed area, it doesn't move with your respiration, and it still appears like white dots, because air will appear as white dots, and it gives you a static air bronchogram. And then there is a shred sign. Shred sign is not exactly the broken pleural line. It's not a broken pleural line, but it is a border of consolidation. So the border of consolidation appears quite shredded and broken, and it is also known as a fractal sign. And we'll see in the upcoming slide what it looks like. Right. You can see a small area of consolidation here, atelectasis. So, and you can see, you know, when you have this atelectasis or collapsed area here, you can see your lines are broken. It's an irregular line. So this irregularity, or this broken border of this atelectasis or consolidated area, is called as a shred sign. And talking about this static bronchograms, you can see these small dots and pecks of air trapped inside, which is not moving with the respiration. It's all static. So those are the static air bronchograms. Similar kind of a picture here. The way to differentiate atelectasis, you know, from the consolidation, one of the thing is, like, you know, atelectasis, with the baby's breathing movement, it tries to open up. So when it tries to open up, you see more of a B lines, and as soon as it collapses again, you see this shred sign coming into picture. Here is also an area of small atelectasis. So it tries to open up. So whenever it opens up, you see nice smoothen out B lines. Which is not nice, by the way, for the baby, but you can see it smoothens out. But as soon as baby expires, it collapses back. So that is more of a nature of an atelectasis rather than a pneumonic process, where you will see dynamic air bronchograms. You don't see dynamic air bronchograms in atelectasis. Right. Again, the static bronchograms, if you see the small pecks of air. Right. Again, this broken area here, you can see, is your shred sign. It is not exactly pleura, but the border of the consolidated area. And this is one of the condition here when you have, you know, this pleural effusion. That is the time when you see actually the lung. Otherwise, you never see the lung. You always see the pleural line. So what we are seeing here is your, you know, fluid-filled air bronchograms. These black areas surrounded by the white packs, if you see, these are the fluid bronchograms. They are dynamic in nature, and they sort of tells you that there is some kind of a infective process going on there, and it's sort of pleural effusion there, which is pushing onto the lung and giving it this particular appearance. And of course, there's a consolidated area here all throughout, so you can see a shredded sign or a fractal sign. And that's your dynamic air bronchograms. As I mentioned, they are moving. It moves because there's fluid field. Again, a nice area, well, not nice, an area of consolidation here, where you can see anechoic or hypoechoic center. Again, very suspective of infective process, pneumonic process. And you can see quite a broken, I would not say pleural line, but quite a consolidated area with a broken irregular margin. So that's your shred sign. And this anechoic area is your consolidated area. Again, because we are talking about consolidations, all consolidations are not mnemonic. That is very important to know and to understand. And hence I put in a slide for the subpulmonic consolidations. The subpulmonic consolidations are sort of a hallmark sign for the neonatal RDS. I think Alok's going to cover that in the next session. But the purpose of putting this slide over here is just to let you know that all consolidations are not infective. Subpulmonic consolidations are more indicative of a RDS pathology rather than infective or collapse or atelectatic area. So you see subpulmonic just at the level of the pleural line, and you don't see dynamic air bronchograms with the subpulmonic consolidations. They're very, very micro areas of consolidations because of the lack of surfactant. So that's subpulmonic consolidation. And you can see quite a white out lung here. But I'm not going to spend much time on this because Alok's going to cover this. Again, just to show you the example of subpulmonic consolidations. Right. Pleural effusion, again, is indicative of, not always, but most of the time, of a pneumonic process. And sometimes you can have pleural effusion because of hemorrhage or, mal-aligned long lines with PN in the pleural space. So how do we get to know and what are the signs? So it's anechoic area separating parietal and the visceral pleura is the pleural effusion. There will be an absence of pleural sliding, of course, because that's your parietal pleura. Normal sliding is your visceral pleura slides against it. You have a fluid in between them. You lose your sliding. So you don't see a sliding anymore here now. There is something called as quad sign, which I will show you. It is about when you scan that particular area with the pleural effusion, you see a quad sign, and then you see curtain sign and the jellyfish sign as well. It's too many signs to know in a one-day session, so we'll keep on repeating this as we move forward with the with our sessions in future sessions. And then when you interrogate that area with the M mode, you see a sinusoidal sign. I'll explain all of those. So coming to quad sign. Right, so that's your rib. This is a rib. This is parietal and the visceral pleura, the sharp line there. This is your anechoic. Fluid is anechoic, is always black because ultrasound waves passes very easily to the fluid. And then if you draw two lines, so quad sign is four borders. So parietal pleura, visceral pleura, and through the ribs, if you draw two parallel lines, so that's your quad sign. So this is what you see on your pleural effusion. So that's your four borders, parietal, visceral pleuras, and two parallel lines from the rib. Sinusoidal sign. So same place. if you can see the same area, and now I have interrogated that with the M mode. When you do M mode, you don't see stratosphere sign or barcode sign or anything like that, because it's all fluid filled. It is not air, or it's not air fluid interface. It is only fluid. So these are your ribs, as you can see on your M mode. And this is your sinusoidal sign. All this black area here is your fluid. So ribs. So it comes as ribs. Anechoic area, black in M mode. And then you have your pleura or the lung coming in the picture. Now, why do you get a sinusoidal sign? Because with each respiration, your lungs moves in and out, or you can say up and down. So as lungs keeps on coming near, to and fro from the transducer, so it generates an image like a wave, because it's moving like that. So it's going towards the transducer, away from the transducer, towards the transducer, away from the transducer. So you get a nice sinusoidal sign. Jellyfish sign. Again, don't ask me why only jellyfish. I don't know, but the movement of your lung, the kind of movement you see here, flapping of the tip of the lung in the pleural effusion, is a jellyfish sign. You can name any fish, but yeah, it's a jellyfish sign. So movement of the tip of the lung in the pleural effusion. So that's jellyfish. And when you zoom in this particular area and you scan here, then you will see this tip coming in the view and going away from the view. If you see that, that's called curtain sign. So like a curtain, it comes and closes that gap when it breathes, when the baby breathes in, and with the expiration, it goes away like the curtain, and then it opens up this space. So curtain sign. Right. So pneumonia. It's a clinic that always has to be a clinical background with PROM, maternal sepsis, chorioamnitis, you name it. It's always a non-homogeneous disease involving the segment or the lobe of the lung. It is very rare that you will see both the lungs, both right and left, involved, the pan involvement of the lung. It's very rare. It can happen, but so far I haven't encountered. It's more sort of a non-homogeneous affecting one particular area of the lung. Pleural line always become coarse and thickened, you can imagine, because it's an inflammatory process. It inflames the pleura as well, hence the look of coarse and thickened pleura over only the involved area of the lung. The rest of the lung, you will see nice and discrete pleural line, but over the involved area, you will see a coarse and thickened pleural line. Lung sliding may be absent in the particular area of consolidation. There will definitely be air bronchograms. There might be a fluid bronchogram. You will see a stretch sign, which is stretch sign, and the consolidated area, which is called a C profile. And if you have a pleural effusion, you're going to see the quad sign and the sinusoidal sign as well. Coarse and thickened pleural line this is what I was talking about. So it's more sort of so this is a discrete line here. It's very, because this is a non-involved area. And when you come down here, where is the pneumonic process is ongoing, you can see it is broken and it is quite thick. Right. I think we are coming to the end of it. Now, pattern recognition, same thing. We have just clubbed it and said, this is A profile, this is B profile, this is C profile. So A profile, you only see A lines. This is a pneumothorax area. You don't see any pleural sliding here. There is no movement whatsoever. So A profile, and if you read a blue protocol, A prime profile. Again, same thing. So here, this is A profile with, you can see a nice pleural sliding. There's a lot of pleural sliding going on. There you can see, B lines also coming up, reaching all the way to the bottom of the screen. So again, A profile or bamboo spine appearance of the, A lines. Right, same thing. A prime, as I said, if you have a pneumothorax, blue protocol likes to call it as A prime. You'll not be wrong to call it as A profile as well. It's just that A profile without the pleural sliding is A prime by definition. A profile All the A lines without the pleural sliding is A prime. You don't see Comet-Taylor effects. You don't see B lines. AB profile, voila. If you see the combination of both, you see A lines and you see B lines as well. Call it as AB line, AB profile. Where do we see it? A lot of conditions, baby getting worse or baby getting better. You can see transition from B to A, and in between you will see AB profile, or baby getting worse, transitioning from A to B, and in between you will get this AB profile. B profile, all compact B lines or coalesce B lines. Think it as a whiteout chest X-ray. So more is the severity, you're going to lose out on the rib shadowing as well. Now, that's not because your ultrasound wave is penetrating through the ribs. It's because of this movement of the ultrasonic waves is so much because of the fluid present there. It's vibrating all throughout. And because ultrasound machines don't have a brain to think about, it generates an image, throughout, and you lose out on your shadowing, acoustic shadowing. So more is the severity of the RDS or the SAID pathology, you will see completely white out. You will see in some of the pictures that it is completely white out. So that's B profile. As you can see here, you can't see any spaces in between. That's your B profile. Because we have spoken about lung point, which is a transition between a normal aerated and pneumothorax. Lung point. Double lung point is a place where is a transition between the area where there is well aerated lung and the other area which is more of a fluid filled lung. Or you can say a combination of, you see a sort of profile in this part of the screen and you see complete B profile on this part of the screen. That's a double lung point for you. So A profile, B profile, and this transition area is your double lung point. We're going to talk, I think Alu's going to talk about it anyway in his session with you guys on RDS and TTNB. You will have a lot of repetition about this, but to understand, this is what it is, the double lung point. Again, similar example, aerated lung, not so well aerated lung. So A profile, B profile, and this transition area is called your double lung point. And as I mentioned, more is the severity, you start losing out on your rib shadowing as well. You can see you're not seeing, ideally you should be seeing this rib shadowing all the way to the bottom, but you can't see that. It's because of the more is the severe, fluid filled area or the pathology, you will see compact and loss of compact B lines and the loss of the acoustic shadowing. Same thing, A profile, B profile, and double lung point. Same about the C profile. Oops. Okay, I don't know why I lost the slide there. Right, I think I don't know, I might have forgotten to put a slide here, but C profile, as I said, any consolidated area, when you see a consolidated area with a lot of B lines, then it's called C profile. C for consolidations. Not it could be any kind of consolidation. It could be atelectasis, it could be pneumonic process, collapse, anything that gives you consolidated shred sign is C profile. And about the pattern recognition, let's not kill ourselves with a lot of information today, but because we're going to go through this again in the upcoming sessions, so I'll not talk about this. But just to understand what we are seeing, I think you guys know now already, this is A profile, A, B profile, some B lines coming up. Again, this is B profile, compact B lines, and this particular area where you can see some consolidations is your C profile. This is what it is, and these are the patterns, and it could be any disease. With the correct clinical context or background, we can come to a conclusion why we are seeing what we are seeing and what pathology we are dealing with. Right. That's the end of my session, and love to answer your questions. Alok, did I complete it within the time frame, or?
Yeah, you've done fantastically well, I would say. So we've got about 11 minutes for questions.
Sure.
What I would say is, guys, who would like to go first?
Can I ask something?
Yes, please, Anna, go ahead.
Hi. Sometimes I see in the screen that A lines are in the bottom and the B lines in the upper field. It's an inverse double lung point.
Sorry, I didn't catch the question. You're saying you see A lines in the bottom and B lines on the top of the
upper field, yes.
Okay.
No, at the top, at the left, okay? In the longitudinal.
You mean cranially, craniocordial
Yes.
is what you meant?
Cranial, I have B lines.
Mm-hmm.
And caudal, I have A lines.
Okay.
It's not usual.
It depends on the position of the baby and kind of a pathology you're dealing with. What it basically means is, the place where you are seeing the B lines is, not well aerated. It's some kind of a fluid is there, and the area where you're seeing A lines is well aerated. Ideally, or most usually, the scenario is on the cranial side is usually well aerated, and you see more of A lines there. And by the virtue of gravity, it's always perlocates to the basal areas and to the R3 or L3 kind of zone where you see most of the B lines. But as I said, that's the ideal thing. Ideally what we see, but it depends on the position of the baby. If you move the position of the baby, you can see the other way around as well, but it's not very usual to see it like that. Sometimes it might be a probe thing, I'm not sure, because sometimes we get engaged with doing the scan so much, we sometimes put the probe in the opposite direction and felt like, okay, the cranial thing we are seeing at the caudal end.
So I think Abhijit has correctly alluded to the fact that it's a reflection of lung aeration. And I mean, what you're really looking at is areas of lung that are well aerated, showing kind of A profile with A lines. And a very classical example that you might see is when you actually give a baby surfactant. And that surfactant redistribution can actually vary. And, sometimes, especially if you give surfactant to a baby that goes down the right main bronchus, you do the right lung and you actually see an A profile, and you do the left lung and you see a B profile. But clearly, even within the lung, you might have differential aeration. One of the other areas that I've sometimes seen patterns like that, when you see meconium aspiration, you've got areas that, are aerated, but areas where you've got patchy meconium. So B kind of lines, B profile, interspersed with an A profile, interspersed with consolidation. So actually everything, a mix of everything. So those are the kind of conditions where you could see this kind of pattern.
Okay.
Just going to, so Abhijit, the next person is Funny Priya. So Funny Priya, would you like to ask your question? While we're waiting for Funny Priya, Dr. Hassoun, would you like to unmute yourself and ask your question?
Yes, good evening. Thank you very much for this amazing lecture. Just I'm confused between two terminology, if you can consider it, between double lung point and AB profile. So when we can label it, this is double lung point, we have A line, we have B line, and in the other way, when can we label it just AB profile? Thank you very much.
Yeah. So I broken it down for the ease of understanding, and it's best not to label that as an AB profile. When we talk about AB profile, it is more of a homogeneous thing. You see all the segments, you're seeing A lines and some B lines, that pattern is called AB profile. Just for the ease of understanding or to explain things in the double lung point, we see A profile. Basically, you see A lines, well aerated lung, and you see most of the B lines on the non so well aerated lung, and that's a double lung point. But to strictly call it as AB profile, it has to be more of a homogeneous sort of a thing. In the same segment you are seeing A lines, in the same segment you are seeing some superimposed B lines. So that is AB profile, not segregated. One side is A profile and other side is B profile, and we call it as AB profile. No, so that is lung point. I was just trying to explain that this part looks like a A profile, this part looks like a B profile. Is what I meant. So no, you cannot label it as AB profile. It has to be a double lung point only, called as double lung point. I hope that answers your question.
Thank you very much. Very, very clear.
Dr. Sujit, I can see your hand raised. Please go ahead with your question.
Hi, Abhijit. Thank you so much for the talk. I had a few questions, if you don't mind. So
yeah, Sujit.
Forgive me if these are fairly basic. So one of the things that I sort of understood from my reading around the literature is when you scan, say, for example, you're scanning R1, are you placing the probe and then storing the picture, or is there a recommendation to slide towards your lateral, your anterior axillary line? Because the thing is that my colleagues have done, it looks like it's a static picture, and then you store that image and then you analyze that.
Static as in, I didn't.
As in, you're not moving, you're not sliding the probe.
Okay, so you are okay. If I've understood you correctly, do we keep the store that loop while we are sliding, or we put it place and we store?
Yeah.
Well, I mean, not such anything that you can't do it. And eventually, like when you are looking at all the zones of the lung, you're gonna eventually slide and see things. So I don't see a reason why we can't store it like that. I always store it like that, and while I'm doing the scan, I slide, go back and forth and see. Especially so when we are thinking of pneumothorax, you have to go through all the zones of the lungs anyway. So it's basically a choice. If you want to focus some particular area and you are convinced, and then you take a loop of that and store it, or while you are doing it, you are sliding ahead, going ahead, and you can and store that as well. But I don't think so there is anything standardized that you cannot do this or you can't do that.
So just to answer your question as well, I support what Abhijit is saying. So there is basically the concept of what is called comprehensive lung scans. Comprehensive lung scans allow you to slide the image so that you can actually get what is called, so if you look at your camera phone, you get a panoramic view, which basically gives you a view of the entire room in a kind of a 3D view. So I'll send you an article which basically looks at comprehensive scanning, which means that you can actually see all the lung fields in a kind of a three-dimensional image. So that is one approach, and that's something that Jing Liu and his colleagues are doing in China. But actually what we would be doing, and this is really important. So when you're doing your kind of longitudinal scanning, you really want to do R1, but for a big baby, R1 obviously is quite a large area. Now it may be that you scan R1 in the medially, and actually you find everything normal. You scan R2 and you have an area that's a point of interest. So I would say that if that's the case, and you're kind of somewhere in between, you can say that, well, this is R1, this is lateral to R1. So you can store both images. But what is important is that if you have a point of interest that's giving you pathology, that you save both images. So, but that kind of approach where you're going to slide your scan, your probe to give you what is a comprehensive image is not possible with every machine.
Yeah. No, the reason I asked that is, so say if you have, I know it in an extremely prem baby, the footprint may cover a fair bit of the chest, but if you have a bigger baby, the point at which you're scanning, obviously you'll see the pathology. Now you can argue that the pathology is not restricted to that little bit of footprint area, but say if it is, a slightly smaller pathology, and if you slide, and if you're getting a different, say if you're scoring, if you're getting a different score, I take it you take the worst of the scores, isn't it?
So what I'd say is that for the BRAT score, the standard approach is to take one clip and look at your worst score. And what I'd say is that, those points as defined by BRAT basically are lateral to the sternal margin, one lateral view and one posterior view. I think overall, when you look at the way it's been studied, I'd say it's fairly, most of the babies, you're not going to get a significant change by moving 3 millimeters here or there. That would be my take on it. The other thing that I would say that's very important, like if you're trying to scan and you're really worried about missing pathology, the pathology that you will miss is consolidation, deeper consolidations, posterior consolidations. So really, I think what I'd say is that comprehensive scanning means you're scanning longitudinally R1, R2, upper, lower, R3, R4, lateral, upper, lower, R5, R6, posterior, upper, lower. But then you have to do what I would say are your transverse scans in each intercostal space. And transverse scans can pick up pneumonia. In particular, the PLAP point, which is the posterior point, is a very common site because a lot of consolidation, mnemonic consolidation, if the baby's supine, will go and the exudate will basically go into the posterior lung fields. So what is really important is that what is the indication for which you're scanning? If I'm scanning for a pneumothorax, air will rise anteriorly if the baby is, supine. So really, I would be able to get most of my pictures by doing the anterior lateral fields, and by moving my probe, I'll be able to identify the lung point. But actually, if you go posteriorly, because air is anteriorly, so if you get what I mean, what really governs how much to scan, how much to handle your baby is the indication for which you're doing the scan. And I think in particular, if you're worried about consolidation, pneumonia, you're looking for BPD and you're trying to define BPD in different areas, you're looking for a focal atelectasis. A comprehensive scan is not just your longitudinal scanning. You have to then scan each individual intercostal space.
No, thank you so much. That's very clear. My second question was, so the 3 ribs and 2 intercostal spaces, what is sort of recommended as the bare minimum? Say if you have, I know some of the pictures we've seen more than 3 ribs, but say if you reduce the sector width, will your resolution sort of improve because you're getting all of that sound into a much smaller area?
I don't think so. It's gonna make a major impact in terms of resolution, because with the of course, if you are using curvilinear or other probes, then it will make a difference, and that's where I was talking about the limitation of the curvilinears and how to use that. But for the hockey stick or linear probes, I don't think so. It's gonna make much of a difference.
Yep, absolutely agree. The one thing I'd say, just if you have a big 4 kilo, 5 kilo baby and you start using the hockey stick, the footprint of the hockey stick is going to be very small, especially when you're starting to do your longitudinal scans. Now, if that is the case, what you really have to do is you have to scan smaller regions. And some authors will use a kind of right anterior upper, right anterior mid, and right anterior lower. And that will technically cover 3 rib spaces. Now, you're really talking 12 ribs. So you might actually be doing 3 to 4 anterior images if you're using a hockey stick, which has a very small footprint, to be able to get your entire longitudinal scan. And for that reason, I love using the linear probe in big babies, just because I'm much more able, I'm quite happy to compromise a little bit on my frequency in that situation, but the anatomy is just a little bit more better defined by using the linear probe. So having both of them is a blessing in disguise. But the absence of it, and as Abhijit will say and mention, and Nadia will tell you, if you don't have it, you use what you have. But just make sure you're scanning all those regions if you have a smaller footprint.
Sorry, lastly, Abhijit, sorry to ask you a lot of questions. The differentiating between consolidation and atelectasis collapse, do you think the plural line will help? Because the dynamic and static air bronchograms, I have to say, they're quite tricky to sort of to tease out. Is there a sort of way to tease out between the two?
I mean, basically, we have to zoom into that sector wherever you are seeing the, this consolidation. I agree that in today's presentation, it is very difficult to, sort of get hold of this dynamic and static air bronchograms or fluid bronchograms for that matter. So you really need to zoom into that particular area to be able to tell if there is a dynamic or the air bronchograms. I'm sorry about my dog. He's getting impatient. About the pleural line, yes. So if it is an atelectasis, the way I differentiate atelectasis from the other consolidation is in the the pneumonic or infective process, the your pleural line becomes quite inflamed, and it appears more thick and gross and broken. Whereas you don't see all those features in the atelectasis, like baby who is being ventilated, or the baby who has some collapse. And when you see that you have instituted CPAP on those babies, that atelectasis starts opening up, or gone up on the pressure, it started opening up. And on those babies, what we have seen or usually seen is that the pleural line is not inflamed or broken or thickened. You don't see those features on atelectatic collapse of the lung, whereas you do see all those in the consolidated area. Plus your the bronchograms, and you can have a fluid bronchogram as well in consolidated areas. Another thing I have not spoken about, because it will be too much for in single session, we also do Doppler of the area in the consolidated area. So when you do that in an infective process, you always see quite a increase in the perfusion. So if you are seeing vessels in that particular, ideally you should not be seeing vessels. So if you see vessels or you see perfused area, then you know that that's an infective process. Whereas you don't see that in the atelectasis. There is absolutely no flow or vessels you can see there. So that's the way to differentiate the two. But just for a sake of a single session, I haven't included all those things. But as we move forward, we will be talking about those areas as well.
No, thank you so much. Thank you.
Alok, I can't hear you if you're talking.
I was going to say, I just wanted to take this opportunity to thank Abhijit for giving us an absolutely amazing talk. So I would say that, we keep learning from each other. We're learning from you, but I've learned so much from the talk today. Absolutely lovely graphics, Abhijit. Thank you so much. Just to say that I will be editing this session. So it might take me about 48 hours to get this on, because this is quite a long session, and I might split it into two, splitting the peer review and splitting this session.
Thank you, Alok. Thank you, everyone, for your patient listening. And I know it was a bit too much in a single day. But yeah, there will be a lot of repetitions, I think, and we will iron it out by the end of the session about differentiating all the pathologies. Lovely.
Lovely. Thank you, everyone.
Thank you.